Welcome to the Let's Talk Health Forum. I'm Dr. Dan Pavlik Jr. We are sponsored by the Access Health and Wellness Association. And this week we are in the world of weight loss. So we have a bariatric surgeon here with us. He is from the Orlando Health Weight Loss and Bariatric Institute. This is Dr. Muhammad Ghanem. Thanks for coming on the show. We appreciate it.
Thank you for having me.
And we're going to dive right into to your world. So tell me a little bit about your history, about your background, and what got you into bariatric surgery.
Yeah, absolutely. So I actually was born and raised in Jerusalem. People seem to find that interesting, the holy city.
Yeah.
And I went to medical school in Jordan. And when I went to medical school, I always knew that I wanted to be some sort of surgeon, but I wasn't quite sure what kind of surgeon. I knew I liked medicine, and I knew I liked to work with my hands. My father was a doctor too, and he was an internist and the complete opposite of me. He likes to think, and he wouldn't even change a light bulb at home. So anything that needed any handiwork, I was the one that took care of it at home.
All right.
And so I did not really get exposure to bariatric surgery when I was in medical school as a student. And then I finished my medical school in Jordan, and I went back home to Jerusalem, and I started my residency as in general surgery. That's what I ended up choosing, and I kind of knew immediately I wanted to be a general surgeon. And during my residency there, I noticed that there was a lot of actually bariatric surgeries going on. And one biggest thing that really blew me away was the metabolic effect, what we call the metabolic effect, meaning the patients who have diabetes and who have all of those medical issues that are related to obesity. I noticed that they would go away completely. And at the time, I had no clue that this was a thing and that it could cure diabetes. So I remember even, talking to my dad on a weekend after I finished, one of my calls, and I told him, let's go grab a coffee. I told him, did you know about this? You can cure diabetes with surgery. I had no clue. This is how shocked I was. And they were doing, kind of different surgeries at the time, but still, some of them are still the ones that we do nowadays. And next thing you know, I kind of started gravitating towards that field. I started hanging out with more and more with the surgeons there. And then the other thing that it was very advanced surgery in terms of being minimally invasive. So you get exposure to, the newest technologies and advancements in surgery. And that is something else that kind of interests me as well, the tech of it as well, the technology.
So when you were a general surgeon, were you seeing a lot of those conditions, a lot of overweight people that you were doing, like, for example, like hernia surgeries on and stuff? And that's ultimately you started seeing these other comorbidities, so to say?
Yes, absolutely. So if you think about it, really, it's not that when you're only a weight loss surgeon or doctor that deals with that you only see the obese patients or the overweight patients. You look at the general population, about 35% of Americans suffer from weight issues. So no matter what you do, you're going to have that exposure to those patients who are struggling with their weight, whether you're a general practitioner, whether you're a chiropractor and talking about back pain, whether you're an orthopedic surgeon or just a surgeon who's trying to fix somebody's hernia and they need to lose weight as a result of that because they can have that hernia come back if they don't lose weight and you fix it immediately. So no matter what, you're going to get exposure.
And of course, weight loss isn't easy. Otherwise, everybody would be thin, right?
Yeah.
So now, when people come to your institute to see you, tell me about that a little bit. What's the criteria? Like when somebody comes to see a bariatric surgeon, they're automatically in their mind, I would suppose, they want to do a surgery, correct? Because if they're bigger, they're like, okay, I heard you were great. I want to do this.
Yes and no. The vast majority of the patients have already looked it up for many, many years, and they come in and they already know they want surgery. They even know which surgery they want. But others are really just there to have that conversation. Others have talked to their general practitioner about it, and they told them, you know what, we've tried dieting, it didn't work. We've tried exercise, it's not working. I had a personal trainer for 3 years now, and my weight, fluctuates 10 pounds plus, 10 pounds minus, but it's not really anything significant. And they said, you might be able to help. Tell me what you got. How can you help me? and they're just open to that conversation.
Okay. So what do you start with in a lot of cases? I mean, like for example, we have recommended semaglutide injections to a lot of patients that want to lose weight loss. Of course, in our world, it's easier sometimes to recommend that than to go straight to surgery, right? So is that something that you guys also provide the for a weight loss option, the semaglutide?
We do provide medical weight loss as well,
Mm-hmm.
but it's not always the best option from the get-go. So first of all, you told me, how do you start? One of the best things about my field, and one of the reasons I like it, is that it's really not just medicine, not just surgery, but also a little bit of it is psychology. So when the patient comes in, a lot of them have this kind of feeling of being defeated. There's a lot of stigma around this issue, and people have put it in their heads that you're just either lazy, you're eating too much, I'm skinny, I don't have this problem. Why is it so hard for you? And they don't understand that this is truly a disease just like any other, and that given that your biology is different,
Mm-hmm.
you might eat a little bit more and you can still burn through it and not have an issue. It doesn't mean that everybody else is. So they come in with that sense of defeat, and I need to reassure them that this is actually not you. This is your biology, and it's a disease, and it's okay. And it's actually been proven that dieting and exercise does not work. Kind of going back to your first sentence.
Yeah. Yeah.
I have to tell them that. And, believe it or not, Dan, you have you can see that sense of relief in their eyes.
Oh.
And probably 50% of them even shed a tear and cry.
Oh, okay.
So we start with that. And
So
then,
understanding, like connecting with them from that understanding aspect.
it's
Number one,
exactly that. And telling them, hey, this is not you. This is a disease. Don't worry.
as a good doctor should, right? Doctors just like that should do that.
Should
So
connect with
that's
the
great.
patient.
That's
Absolutely.
great to hear that.
And so once you really do that, it's tailored to the patient as well. So we talked about medical weight loss and semaglutide, for example. This can be a great option for certain patients. However, others who are a little bit heavier, and then they have a little bit of a higher, what we call body mass index,
Mm-hmm.
it might be a little bit more futile for them to try that medication, semaglutide or any other GLP-1, which is really the group of medications that semaglutide belongs to.
Yep.
Because then at that point, the only thing that has been shown to be beneficial and proven to help them is surgery, and it's going to be probably cheaper, more accessible, and more sustainable for those patients as well.
Wow. So you're just want to talk about semaglutide a little bit because that's the big deal kind of in weight loss right now. There's a lot of negative kind of in the media. There's positive and negative, but you've heard people coming out with all these different issues tied to the semaglutide. Do you have any opinion on that as far as what do you think? I mean, what are you seeing negative aspect, or is it kind of being blown up a little bit more in the media than it should be? Or?
I think it is. Things are taken out of context, and I think when you see that demonization of one thing or another, whether it being a certain surgery or medication, it's because somebody else wants to say that also this is either all good or all bad, and these are the things that attract attention in media,
Mm-hmm.
right? I don't want to give you this kind of maybe answer. This doesn't attract any likes on an article on Facebook.
Yeah.
So the truth of the matter is that things are actually more gray than they are. It's like nobody talks about this, for example, about Advil, right?
Mm-hmm.
Is Advil good or bad? It depends, right? Does it have side effects?
Yeah.
Absolutely.
Yeah.
It can cause ulcers, it can cause kidney disease, but does it also help with inflammation and back pain? Absolutely does too. So there's no really good and bad. It's a medication, it has indications, and it has side effects as well. So the question is, how do you look at it in a sense? The big thing about semaglutide is that it is a revolutionary medication when it comes to weight loss. If you really look up until then, a few years ago, when we had surgery and it was effective and sustainable and very good. But if you're talking about medications, we had really nothing in our arsenal to help those patients.
Mm-hmm.
We have phentermine, which is really a stimulant, also has side effects. Not a bad medication, but doesn't help you lose a whole lot of weight. It doesn't really work in an amazing way. Just really speeds up your metabolism a little bit.
Mm-hmm.
We had a few other options that didn't work as well at all. And this really starts to give you this option of understanding the disease of obesity and how it works and targeting that a little bit too. If you ask me, this is only the tip of the iceberg, and because semaglutide is not the perfect medication, doesn't work for everybody, and it doesn't target everything,
Mm-hmm.
but at least it's the start of something. I
Mm-hmm.
think that in 30 years, we'll be in a much better situation when it comes to medications. But I think at least what gives me hope is that now we're really on the right path.
Yeah.
That's all. We just
Oh,
started the path, but we're on the right path.
that's great to hear, because that's, I mean, coming from your perspective, that this is your world, you deal with this all the time, so you see all the different, ebbs and flows, so to say. But that's good to hear that. That's very interesting to say, oh, okay, we're right at the forefront of this,
Mm-hmm.
and as time goes on, things should get better, for all the patients out there that um, are questioning the semaglutide and saying, well, let me do as best I can right now with it, or see if I can try it, or maybe I can try just dieting on my own, and then let me give it a little bit more time and
Right.
see what happens. But that's very interesting. So, okay, now you've tried some of these other things. Obviously, no success. Now they qualify, or what makes them qualify, or what do they have to go through from a standpoint of you saying, okay, we're going to go ahead with the procedure?
Right. So just the fact that they're suffering from some sort of weight problem doesn't really necessarily mean that they qualify. They
Yeah.
have, to your point, they have to meet certain criteria, right? So what we go with is something that is called the body mass index, BMI. So BMI is not a perfect measure. It really just basically is your weight over your height squared in meters.
Mm-hmm.
And somebody came up with this formula many, many years ago. And that's what decided they're going on. And it's basically a very simple thing. It's cheap. You can do it in the office. It takes 1 second. So definitely is in that sense good. It's not a perfect measure because we have a lot of people who have a lot of muscles. For
Mm-hmm.
example, if you look at professional, athletes, they
Mm-hmm.
can have high BMI
Mm-hmm.
and they fall in the category that they're technically obese, even
Yeah.
though they're not.
They're not. Yeah.
Absolutely. But so it's not a perfect measure in a sense, but it's something.
Yeah.
So they have to have a body mass index of 35 and above.
Okay.
Or 30 to 35 with medical issues related to obesity, such as heart disease, such as diabetes, such as sleep apnea, such as blood pressure, cholesterol, fatty liver, so on and so forth.
Okay.
So if they meet those criteria, that means they technically qualify, unless they have other issues that prohibit them from qualifying for surgery. So the other things that we look into, we have to have them see a psychologist, because anybody who has any active addiction to alcohol or drug abuse obviously does not qualify.
Mm-hmm.
Anybody who has an active eating disorder that is not treated, by definition, should not be having any weight loss surgery, of course, and they should have that under control and treated first. Anybody who has, any other medical issues that, or I should say, mental health issues that are not well treated and controlled, then also they should look into that as well. Having a history of all of what I just mentioned does not disqualify you from having surgery.
Okay.
You just need to be under control, treated, and if it's a history of abuse, for example, to alcohol, as long as you've been sober for more than a year and you have a track record to prove it, you should be fine.
Okay. Very, very interesting. So now, okay, they've gotten to the point. They've gotten the consult with you and the approval to move forward. So now, what are the different procedures? I think there's also confusion out there as far as, the gastric surgery. There's different options that people have, different ways that you guys do it. So
Yeah.
try to explain that.
Yeah,
a little
so
bit.
the majority of them at this day and age are done through minimally invasive means, whether laparoscopically, which means that we make a few small incisions and then we put a camera in and then we perform the surgery, or robotically, which is what we mostly do, which is a robot that you connect to the patient also through small incisions and a camera. Then we sit on a console, kind of like a drone in a sense, and we do the surgery. The robot does not do the surgery.
Yeah.
So,
Okay. Which is a confusing aspect for some
all the
people
time.
out there. They think the robots are doing the surgery, but the doctor still has to control that. So,
absolutely, like a good example that I tell them, it's like a drone. You don't have a pilot inside the aircraft anymore nowadays, right? If you talk to the people in the Air Force,
Mm-hmm.
but there's still a pilot that is operating that drone. Just it's just they're just sitting on a console
Yep.
somewhere else.
Okay.
So there are different procedures that we do. The most common of which is the gastric sleeve. Um, People, when they hear the word sleeve, they think that we're putting a sleeve device or a tube inside their stomachs, but it's actually not true. What we're doing is that we're cutting the stomach, making it smaller to look like a sleeve, kind of like a shirt sleeve, if you will.
Yep.
And so they're able to eat less, and it also works in different hormonal pathways as well to help them lose weight.
Yeah. So instead of the stomach, kind of drooping down this way, you're making it more streamlined to stay consistent to what, the the tube all stays consistent that dumps right into the
Yeah, absolutely.
small intestine.
What we do is we put a tube in that is a certain size, and then we cut everything that is from this. We basically use a machine that cuts and staples at the same time,
Mm-hmm.
and we cut everything that is to the left of that tube. And so we take that part of the stomach out that we cut, and now you have a much smaller stomach that is the size of that tube, and we take the tube out at the end of the procedure. So
Okay.
it's really
Very
we're
interesting.
not leaving any foreign bodies inside that,
yeah.
as opposed to the lab band that was something that we used to do back in the day, and we
Okay.
don't do anymore. Where we used to put a ring around the stomach.
Yep, I've heard about that. So that is no longer.
That is
Okay.
no longer.
Okay.
Very few people do it still, but the majority of the surgeons do
Okay.
not do it nowadays.
So that's the gastric sleeve. The gastric bypass.
Mhm.
How does that differ?
The gastric bypass, we're actually not taking anything out of your body. We cut a small pouch in your stomach, think the size of an egg, forming it from your actual stomach. And then we disconnect a piece of small bowel and we connect it to that pouch. So now the food has about a very small pouch to go through and then straight into your small bowel. And it's a very good procedure. It's a procedure that has been around since the 1960s. Of course, it wasn't done in minimally invasive techniques at that day and age, and it was much more dangerous. Now, very safe.
Yeah.
And in a sense, you can say that it has a proven track record of we know what it does well, we know what it doesn't do well, we know which patients are good candidates for it, and the other way around.
Yeah.
And it helps a lot with patients who have bad reflux and heartburn, and it helps a lot for patients who have bad diabetes as well, because they get this surge of GLP-1, which is how semaglutide works,
Mm-hmm.
with other hormones too, as soon as you do the surgery, to the point that you have the blood sugars on diabetic patients normalize fairly 2 to 3 days after surgery. It's almost magic.
Wow.
You kind of asked me when we started how I got into it, and that was one of the things that got me into it. Seeing those patients, literally, I thought initially that okay, they lose weight, their blood sugar gets better from the weight loss, but it's actually not with the gastric bypass or the other procedures that we do. It's because of those hormonal changes that happen with it, and even before they lose any weight, the
Wow.
blood sugar is starting to normalize.
Interesting. I don't think a lot of people really knew it from that perspective.
Not at all, and I think a lot of other doctors don't. And every probably month, I would say, I get a patient of those tough diabetics that are basically on insulin with the pumps. So they have what we call Dexcom. It's a continuous monitor for their blood sugars. And as soon as they come in for that first visit, which is usually 1 week after they go home, and they shed a tear and they show me that and they just start crying. They tell me, I don't remember when the last time was that my blood sugars were this low and this normal. I haven't seen this in a while, and they can show you the graph on their phone with the app being connected. It's fascinating.
Yeah. Well, that's awesome. And it is really interesting, like listening to it from this perspective, because you just have things in your mind like, oh, gastric bypass, whatever. People just cut the stomach smaller, they start losing weight, and that's it. So hearing it from how it actually works in the body and what other things start to engage, that's really neat.
Right,
So
absolutely.
other procedures that you also do instead of those two, or
Yeah, so we do also quite a bit of what we call the duodenal switch. We call it DS for short, and it's really a combination of the two. We cut the stomach and make it smaller by starting just like the sleeve that we talked about
Mhm.
first, and then we bypass part of their bowel as well. That gives them that hormonal benefit for the insulin resistant or diabetic patients too.
Hmm.
So this gives them actually quite a bit more weight loss. It's a great procedure for those who are a little bit heavier and they have a lot of weight to lose and they have bad diabetes too at the same time. But it's an interesting procedure in many ways because this was a procedure back in the 80s that they used to do a little bit differently to the point that it had a little bit more issues, and then they abandoned it. And with time, it started coming back, but with a modification. So now we can do it quite safely without having lots of complications, just as safe as the bypass and the sleeve, with excellent results with it too. So it's going to make it a comeback. And now, if you go to any of our meetings as bariatric surgeons, nation or worldwide, this is the kind of hot topic that everybody's talking about, that
Okay.
procedure.
Okay. So this is probably not the best question, but when somebody comes in to see you for a consult and you start talking to them and you look at their history and their blood work, do you already kind of know in your head what procedure you would want to do with them out of these 3 surgeries that we talked about?
Absolutely.
Yeah.
No, it's actually a very good question, and absolutely, you look at the chart, you talk to them, you ask them their history, their eating habits. You already know with when you have enough experience that this is the best procedure for you. And the biggest struggle that I have is when you see this and say, for example, I have this patient that I think is a perfect candidate for a gastric bypass, and but they've already made up their mind that they want to have the sleeve done because quote unquote, my cousin had it and she did great. And I hear this a lot, and then you tell them that it's not a one size fits all.
Mm-hmm.
If you're coming to me as a professional, you got to trust me as a professional too, right? So
Absolutely.
you know,
So do they end up changing their mind and listening to you?
almost all the time.
Yeah.
Yes.
Okay.
Yeah. If people are smart nonetheless,
Yeah.
and I think if you give them and talk to them rationally and give them the reasons why you think this procedure is best, and you explain to them that you know, even though somebody told you that the bypass is not good, it's actually a very safe procedure. It's not more invasive than the sleeve, so to speak, or so. They'll listen to you and they'll.
Which is an important point when, as a physician, everybody is different. Everybody is different. You cannot come in based on, you can come in with the thought of, oh, I want to talk to you about this because a friend of mine did this or a family member did this and they did really well, but every person is different and the doctor is the professional to make the decision on ultimately what's best for you. So I'm glad you said that I'm glad that was ended up being a good question. I wasn't sure. You never know, it's like, so, all right, procedures are chosen and performed. What are success rates as far as like out of these 3 procedures? Is obviously, I would assume, a pretty high success rate.
Absolutely.
However, there's got to be
Mm-hmm.
some complicating factors or some complications or just things that don't allow them to work. What would that entail?
Yeah, so very successful all in all. Most people do well in terms of weight loss and in terms of their medical issues that have led them to have this, for example, their diabetes, their blood pressure, their cholesterol, etc. Some patients do gain weight back. So about 20%, so 1 in 5 patients can gain some weight back, not necessarily all of it,
Mm-hmm.
but at least some weight back afterwards. And even those who do gain the weight back, studies have shown that the majority of them still do better in terms of their diabetes is still gone, their sleep apnea is still gone, their blood pressure is still gone, etc.
All right.
So they still do well in terms of the medical issues, but the weight can come back in 1 out of 5 patients too.
Okay. Now, what after the surgery? How long? What's the downtime?
Mm.
How long are they, in the hospital or in the institute where you guys do the procedure? And when you said there's a week follow up, a 1 week follow up, correct? So how long is their downtime? Is it the typical like 4 to 6 weeks that you don't want them really doing much? What's that usually?
Yeah,
look
so
like?
they usually stay at the hospital for 1 night. Some patients who have the sleeve done can even go home the same day if they're younger, they're healthy, they don't have any other issues. So depending on the procedure, either outpatient or you go home the next day. So typically not more than one night at the hospital. You go home, you should be able to really perform the majority of things on your own. Go to the bathroom on your own, get up and walk around, get dressed, etc. You shouldn't need that much of an assistance. However, of course, we do recommend that you don't do physical activity that is more than walking or, just a little, if you want to get on a bike, just a little bit for about 4 weeks after the surgery. No heavy lifting, nothing crazy.
Yeah.
The majority of people who have desk jobs should be able to go back to work within 2 weeks after the surgery.
And do they have to then meet with like dietitians to learn obviously the new ways to eat now? Like,
Absolutely.
and so what are the what are the rules as far as what they cannot have, what they cannot eat when they have one of these procedures?
Yeah, so it depends. If we're talking immediately after surgery, they're on a fairly strict diet that progresses from having only liquids for the first 3 days and slowly starts progressing into more solids as we go. And they're usually back to a normal diet within 7 weeks after surgery. So, initially it can be quite restrictive for about 7 weeks after surgery. But then afterwards, to be honest with you, Dan, there's not a whole lot that they should not ever touch. Studies do show that those kind of things that you can put in rules that they say this is off limits, it doesn't work. And nothing should be off limits in a sense. Food is meant to be enjoyed. Food is even a social necessity for most of us, right? When you want to go with your with your partner later on Friday evening, you guys go out to eat, right? When you want to go with your friends, you go have a drink or eat as well. The question is, of course, how much. And the problem is that moderation can be misinterpreted for some people too. But to say that there should be something they should never ever touch, I think, is a little bit of a unsuccessful story that we've tried in the past.
Okay.
Things that they should be really careful with are refined sugars because those have been proven to be addictive. So having that ice cream once every 3 months is not going to ruin your weight loss journey. But if you're having it every week, it actually will.
Okay.
So, and then once you have it, it does trigger that reward system in your brain that you want to come back tomorrow for.
Yeah.
Too. So the question is it off limits? No. But also, do you have the willpower to say, I don't want it as well, even though it is going to try to get you?
Oh, that's interesting. I mean, you would hope everybody has the willpower after they go through something like that, like a surgical procedure like that. But I'll tell you, man, that answers a lot of what I have, and probably what a lot of people out there listening have as questions. I do have a question though, as far as one of the largest patients you've encountered or had to treat in the past, size wise, just kind of I'm just curious.
Yeah, so I think one of my heaviest patients was a very nice lady that was about, I think, 800 pounds, if I remember correctly.
And at that point, they can't really, walk into the clinic, right?
No, they're immobile, and that makes things obviously quite a bit more complex. So what you have to do is try to stage the procedures and try to get them to be mobile as much as possible. So what I end up doing is a duodenal switch, which is what we talked about, but I had to do it in phases. So we did the sleeve, which is cutting the stomach and making it smaller. Had her get off oxygen. She was oxygen dependent.
Wow.
Had her become a little bit more mobile with a walker, but that's still a big win for somebody who wasn't able to walk at all. And then once you really, once we got her there and she was very happy with the duodenal switch component, and then she had a brand new life after that.
Wow, that's great to hear. Well, we appreciate what you do. I love your passion for medicine and for what you do. And, this is what this show is all about is, allowing everybody to listen to what these doctors, what their story is and what they do. And, treating these patients. That's why we get into the medical field, is because we want to take care of people no matter what negativity is out there. I'm trying to get a lot of these guys that I would trust, in my world, and in my referral aspect, or my family needing help, and I want to introduce everybody to these people. So we greatly appreciate you being on this show,
Thank
Dr.
you so much.
Ghanem.
Thank you for having
And
me.
he is with the Orlando Health Weight Loss and Bariatric Institute. Dr. Ghanem, I would definitely refer to him and trust my patients with him. And I hope everybody got a good amount out of this show today about the world of weight loss. And we look forward to talking to you, interacting with you, and educating you in the Let's Talk Health forum. So until next time, I'm Dr. Dan Pavlik Jr. We'll see you.